This webcast and any accompanying materials are copyrighted by the American Association for Respiratory Care. Any public display, sale, copy, or distribution of the video or materials may be only undertaken with prior written consent of the AARC. Copyright 2012, all rights reserved. My name is Bill Dubbs. I am the AARC Director of Education and Management Services, and I welcome you to today's webcast on cardiopulmonary exercise testing, performing quality VO max assessment. Upon completion of the program today, you should be able to describe the workflow quality model as it relates to cardiopulmonary exercise testing, review recommendations from the guidelines and current literature as they relate to cardiopulmonary exercise testing, describe testing nuances that can improve cardiopulmonary testing results, and define the key components used to assess a therapist's competency. I am pleased to introduce Carl Mottram. Carl is an AARC Fellow and a registered respiratory therapist. He is also a registered pulmonary function technologist. He is the Director of Pulmonary Function Laboratories and Rehabilitation at the Mayo Clinic. Carl is also Associate Professor of Medicine at the Mayo Clinic College of Medicine. He is recognized as an expert on cardiopulmonary testing, an author or co-author of at least a dozen papers listed in Index Medicus, and a frequent lecturer at state and national conferences. Mr. Mottram discloses that he has no conflicts of interest related to this presentation, although brand names of technology or products may be mentioned as examples of technology. Carl, welcome to the program.
And welcome to all of our participants from lovely Minnesota. I'm looking out of my office window with just blue sky and nice floaty white clouds going by, so it's a very pleasant day here. Well, as we talk about exercise testing, we kind of look at, where the recommendation come from as far as how we do that particular test. And many of the professional organizations out there have put out recommendations or guidelines related to exercise testing. The American Heart Association has a recommendation that they published for clinical exercise laboratory in Circulation of 2009. The American College of Cardiology and the American Heart Association have a joint guideline that was updated in 2002, and the ATS and the ACCP, the American College of Chest Physicians, have a statement on cardiopulmonary exercise testing that was published in 2003. There are also guidelines for the pediatric age group. And so the American Heart Association Council on Cardiovascular Disease in the Young published a guideline in 2006. There's a guideline related to clinical competency for stress testing that came from the American College of Cardiology and the American Heart Association. And then the American Thoracic Society also has their Pulmonary Function Laboratory Management and Procedure Manual, which was updated in 2005. I actually wrote the two chapters along with several others, but the two specifically on exercise testing. And that's more or less just how to go about it. But it's a very nice resource because it comes to you in a Word format that you can modify if needed, and it is reference-based. Well, I'm going to kind of take the approach for this whole lecture in going through exercise testing and how can a respiratory therapist influence getting a good test by using a quality model that comes out of the Clinical and Laboratory Standards Institute. I have the esteemed pleasure of being involved with this organization. I originally started as the AARC's representative because they were writing all the standards and guidelines related to blood gases. And we wanted to have some influence on how those guidelines were coming out, so I started with that. And then through my volunteerism over the years, now I actually chair their Quality Management and General Laboratory Practice Committee. This organization writes all the guidelines and standards for all of laboratory medicine, so it's quite an honor. And in there, this organization took a a quality model from the International Standards Organization, ISO 9000 guidelines, and applied them to the healthcare model. And we then took that same quality system model and applied it to respiratory care services. And in this quality system model, and the thing I learned from this whole experience in writing these guidelines and getting the literature related to them, is you look at the path of workflow. In other words, getting a quality product, whether it be a car coming off of the assembly line, a widget, a diagnostic test, or managing a ventilator within an ICU, requires that you look at everything across a particular path of workflow. And so the interaction with the patient is all across this path of workflow. And if we look at this more specifically as it relates to laboratory tests or the tests that we provide within the diagnostic lab, you have things that happen in the pre-examination or pre-test process. You have things that happen during the test itself, and then after the test is performed. And you apply a group of quality system essentials, which are listed on the boxes below the large arrow there, such as personnel, and or the equipment, and or information management, and you apply all of these quality system essentials across the path of workflow. So we're going to take that approach as we look at cardiopulmonary exercise testing. So in the pre-testing environment, we have to make sure that we have correct demographic information. We have to make sure that we review the patient's history, that we know their working problem list, that we know their differential diagnosis, that we look at, what are their current exercise limitations, and or when we're interviewing the patient as they're coming into the laboratory, we find out a little bit more about them as far as, what is their exercise limitation? What is their degree of dyspnea? Do they have any orthopedic considerations that we need to take into account? Such as, I just had knee surgery, and so I'm not going to be able to exercise on a cycle ergometer. I can only, because I won't be able to bend my knee. And all of these other kind of things. We need to look at their laboratory results, to look at their pulmonary function tests, to look at their electrocardiogram if they have one in those results, and maybe even some of their lab results. We need to know what medications they're on. Are they on a beta blocker, a calcium channel blocker, that will affect their heart rate response as they're performing this exercise test. You don't want to be encouraging someone to reach a maximum heart rate of 180 when they're on a beta blocker and their maximum heart rate's only going to get up to 120 or 125. So these are all the things that we need to do on the front end before we even perform the test itself. Also in the pre-testing environment, we need to make sure that the patient is given pre-test instructions. And I have an example of our itinerary or our pre-test instructions that are given to the patient when they arrive in our laboratory here. And essentially it spells out for them what are their expectations before they arrive. When I talk to people about this, or even the pre-test instructions for a pulmonary function test or any type of diagnostic test, I often use the analogy of having a fasting glucose. If a patient doesn't get those pre-test instructions not to eat prior to midnight and they have a Snicker bar at 2 in the morning, well, that certainly is going to affect their lab results in the morning when they have that blood draw. Well, that's the same thing with our patients. We need to make sure that they're prepped for the test. So these patients should come in wearing appropriate shoes and clothing. We test young people all the time, and here they walk in for an exercise test with flip-flops on. And so you need to make sure that you've instructed them on the front end to wear appropriate shoes, wear appropriate clothing, refrain from smoking, eat a light meal a couple hours beforehand, but certainly not go out and have a Thanksgiving dinner before they come in and do your exercise test. Make sure that you have something in there about medication instructions, and all of that is presented to the patient so they arrive in the laboratory ready for this test, and they'll be able to give you their best effort. And then review the order also. Sometimes the physician will just click on or a VO2 max study or a cardiopulmonary exercise test, however you have your order set up. But maybe the patient, based on their pulmonary function results, such as a diffusing capacity that's 50% of predicted or something, may need to have blood gases drawn during the exercise test, or you may want to do flow volume loops during the exercise test. So you want to kind of review their history, review the data that's been presented to you on the front end, and then maybe you need to order or perform some type of additional test during the exercise itself. As far as pre-test calibration of the system, in our institution we calibrate our system prior to every test. I know that some people will calibrate their flow sensors at the beginning of the day maybe, and then their analyzers just before the test. But certainly we need to make sure that they are calibrated and meet the ATS-ERS standards for flow volume measuring devices. The gas analyzers need to have a 2-point calibration tested over a range to make sure that they are functioning accurately. Something that we presented in the literature back in 1996 was looking at the phase or time delay and the effect that it can have on the measurement of your oxygen consumption. And in this particular paper that came out of our lab, we looked at this. Now the phase delay is either the oxygen analyzer phase delay or time delay, or the response time of the analyzer, and or the response time of the CO2. And you need to look at both of those. They come out on the calibration report. You can look for either phase delay or time delay. And they will have a substantial impact. In this particular study, we ended up, depending on how that phase delay was set, and the phase delay is on the x-axis here, you could have a 25 to 30% swing, either negative or positive, on the outcome of your VO2 measurement itself. So it's a very important variable. Things that can affect the phase delay is if you get water or dust or dirt in your sample line, if you get a kink in your sample line for your analyzer system, all of those things affect the phase delay and can have a profound effect on your test results. The next thing in the pre-testing environment is we need to choose the right ergometer. Well, what is the right ergometer? Sometimes the right ergometer is what you have in your laboratory. Some laboratories only have treadmills. Some of them only have cycle ergometers. We actually have both here at our outpatient lab at the Mayo Clinic, and so we can choose either one. We typically choose the cycle ergometer, but that's just our particular preference. In our cardiovascular health clinic, they choose the treadmill more frequently. But once you choose that ergometer, making sure that you position the patient correctly on the ergometer is important. If you're using a cycle ergometer, you should seat the subject on that particular ergometer and make sure that they have only about a 10% break in their knee with their foot horizontal to the ground, and that should be the appropriate location for the saddle height. It's very common that subjects or patients will say that, oh gosh, you have this seat very high, because it's very common for novice to have the seat actually too low. But you want to make sure that that quadricep has an opportunity to stretch out with each stroke of the pedal, and that way the muscle itself won't tighten up as quickly. So you want to make sure that you adjust that correctly. If you're using a treadmill, you want to make sure that the subject stays forward on the treadmill, that they use the treadmill only for light touch as far as their hands go. If someone actually grabs on to the treadmill handrails and holds on, they can go to at least one additional workload just by reducing the amount of work that they're doing. If they do need to balance, it's okay if they use light finger touch on the treadmill side hand railings, or in the front railing, but nothing more than that. And so that's very important also. Well, what are the kind of the advantages and disadvantages of both? Well, the treadmill itself, one advantage is it's a natural form of exercise. Now, that's kind of a funny statement in itself, because if you've ever seen anybody exercise on a treadmill for the first time, half of them don't walk or can't walk correctly on a treadmill. So it's usually a good idea to have some type of small introduction as far as how to walk on a treadmill. Make sure you take a normal stride, that you use a heel to toe approach as far as your placing of your feet, and make sure that they're very natural about it. It is a natural form because you are moving your entire body mass, and so the treadmill usually has a little bit higher VO2 max than a cycle ergometer will. The other thing nice about a treadmill is that it's very easy to calibrate. The disadvantages of a treadmill is that there's a risk of accidents, and I've seen individuals who have done face plants on treadmills or tripped or fallen or whatever, and so you do have to make sure that you're aware of that. There also tends to be a lot more motion artifact, especially if the subject is fit enough that they can get up to a jogging or running pace. It becomes a little bit more problematic with motion. It's a little bit more difficult to obtain blood samples if you're doing that during the exercise test, and it's a little bit more difficult to quantify work because you really don't know how much work someone's performing on a treadmill. There are some algorithms for that, but you really don't know as you go along. Now, on a cycle ergometer, the advantages are that it's safer. If someone's going to pass out, they can kind of melt into your arms, or stabilize themselves a little bit before you can get them to an exam table or something else along those lines to have them recover. It's much easier for monitoring because there's less noise. It's very easy to quantify work. The output of a cycle is either in watts or kilopon meters per minute. It's easy to obtain blood samples even if you don't have a line in place, because you can just have them lay their arm out over the handlebars and you can draw a blood sample with that. The disadvantage of today's modern cycle ergometers is that they are difficult to calibrate. Matter of fact, there's no way to calibrate them other than using biological controls, and we'll talk about that a little bit later. I really shouldn't say there's no way, but the calibrators that are associated with them are rather expensive. I think they cost about $5,000. They actually apply a motor to the flywheel, and they can figure out or calibrate the output. You do have more problems with leg fatigue, but that's why it's important to make sure that you have the saddle height adjusted appropriately, and it will yield a slightly lower VO2 max, although you certainly can push a subject to get up to their VO2 max on a cycle ergometer. How we choose the protocols that we're going to use can have an effect on the quality of the VO2 output also. Certainly we either have cycles or treadmills, and you can either do steady state, incremental, or ramp protocols. Incremental protocols usually start out with a little bit of a warm-up, and then every minute they go up in slight increments of work. A ramp protocol is computer integrated and is a steady increment in work as we go throughout exercise. And then we have these different protocols that we can use. In treadmill testing, Bruce protocol is probably the most common use. It's interesting that the original work was performed on only 295 subjects. This is where metabolic equivalent came from originally with his work. But it does have a very reproducible VO2 max. And Mayo does have some normals that they published as far as the amount of exercise time that someone should do on a Bruce protocol. So a Bruce protocol is a defined protocol. Every 3 minutes the workload goes up. So you start out at 1.7 miles per hour up at 10% grade, and then the next workload is 2.5 miles an hour up at 12% grade, and each one of those stages is 3 minutes long, and depending on how long you go is where you get into your normal ranges as far as time goes. They've been adapted for children, and then there are other protocols which have smaller increments in work, like the Naughton and Bulky, and then there's a variety of modified protocols that are available to you out there also. You can do a ramp test on a treadmill. There was a article that was published out of Castleberry's lab in 2003 that looked at varying treadmill speeds and grade in type of increments that allowed them to create a ramp output kind of like you would in cycle ergometry testing, and this is the reference for that. In cycle testing, several authors have produced normal values for that. Norman Jones' data is probably the most popular. It was done on around 1,100 subjects with an age range of 15 to 71. He used a 1-minute incremental protocol. Wasserman's has a protocol out there also. He's kind of the founding father of cardiopulmonary exercise testing, and of course many of you may know of his text. Although I don't believe he is this particular reference is necessarily all that good, because he tested 400 shipyard workers to represent normal population, and I'm not sure if that's a correct way or a correct method to use. Not too many shipyard workers out there. Stephen Blackie is another individual that tested individuals and produced normals in the older subjects, age 55 and up, and so he's a very good author to choose for reference cycle ergometry testing in older individuals. In 2009, there was the SHIP study. It had 1,700 volunteers. It was part of a study of health in Northeast Germany, and the data that came from that showed fairly decent correlation with some of the other authors out there as far as age and predicted VO2 ranges. As you can see, when you're in your 20s, your predicted VO2 is around 30 or so mils per kilogram, and as you age, that continues to fall until you get down around 20 mils per kilogram. How in a cycle ergometer, if we're not using a standardized protocol where every 3 minutes you increment it up, but you're using a ramp or a step incremental, how do we go about choosing what the workload is that we should start out with? And there was a formula that was published in the ATS ACCP guideline that used time constants and slope and all that other kind of stuff. They must have had, you know, a PhD mathematician involved in this particular section. But anyhow, probably an easier way to go about it is when you put all the demographic information into your system, as far as height, weight, age, sex, and everything else, it will put out a predicted VO2 max level. You take that predicted value minus the resting value and divide it by 10, and that will give you your predicted maximum power output in watts. The reason why the 10 is that it takes about 10 mils of oxygen per watt of work. So as an example, if we took an individual, inputted their demographic information into the system, and it says that their predicted VO2 max is 2,300 mils, we would minus a resting value of around 300 mils, end up with 2,000 milliliters, divide that by 10, their predicted maximum VO2 would be, or predicted maximum workload would be 200 watts. If we wanted to get that individual there using a ramp or incremental protocol in 10 minutes, we would then divide that by 10 and use a 20-watt incremental or ramp protocol. Now that's if we expect them to reach their predicted VO2 max. If for some reason they have lung disease, heart disease, they're out of shape or whatever, then we would need to reduce this workload and use a lower value to increment their workload. Or if they're a marathon runner and you're checking their exercise and that type of an individual, you may need to increase that workload increment slightly or adjust it appropriately. But at least this formula allows you to get to, that stage of, okay, I'm going to say that this individual needs to go on a 20-watt ramp protocol. And that can have a tremendous impact on the overall exercise, because you want, Wasserman and Hansen published a paper way back in the 1980s that stated that the optimal length of an exercise test is somewhere in between 8 to 12 minutes. And so that's usually why I target 10 minutes. That way they can exercise, focus in on exercise. We get enough data to process and analyze, but yet they're not exercising for 25 minutes or 30 minutes and just becoming fatigued rather than focusing in on where they're going to go from there. Now during the test itself, there are other things that influence the quality of the test. Those are, does the patient understand the instructions? Do they understand the kind of effort and cooperation that is needed to give us their best effort? And so you really need to spend some time when you're introducing the test telling them that, we're going to monitor you, that you're going to be completely safe, that we want you to give you your best effort, we want you to go as far as you possibly can. If there's any reason to stop the test, we'll tell you to do so and cool down. But other than that, we want you to give you your best effort, and you need to encourage them to do that. There's also the technologists or the performing individuals' performance and training, and we want to make sure that those individuals are competent. And so the technologist, therapist, or nurse, or whoever's performing the test should have the appropriate job qualifications. They should have a job description that includes cardiopulmonary exercise testing. They should have an orientation and training period and documentation related to knowing the nuances of conducting a test so that they can be competent. They should have continuing education, and this should be part of their performance appraisal. And I have our competency assessment process flow chart over there on the right side of this particular slide. As far as recommendations for specific personnel, medical supervision is typically warranted, although there are a lot of places that perform this test with trained individuals, trained allied health professionals, and the physician just available if needed. At our institution, we usually have a physician present in all cases, but we're a training academic institution, and so we have fellows that are rotating through the lab, and we have a staff consultant that is always in the lab, and so it's pretty typical that we have someone in there. As far as the testing personnel itself, they should be familiar with exercise testing. And I'm going to chat about this just a little bit later as far as how that can influence the outcome. They should have a basic understanding of exercise testing. They should have knowledge of an abnormal exercise response, and they should be trained in BLS and ACLS as encouraged. During the test itself, you should start out by getting some resting measurements, their resting blood pressure, their ECG, their ratings of perceived exertion. They should have had spirometry or something on the forefront prior to the test itself, so we can look at ventilatory capacities and other parameters, breathing strategies and everything. You want to select the appropriate device and protocol, and then you want to exercise the individual, monitoring their electrocardiogram every workload and their blood pressure every 1 to 2 minutes. As far as electrocardiogram, you want to make sure that you test the system beforehand. So, you place it on them. That you use a 10-lead Mason Lickar placement, which moves the limb leads up to the trunk area, and just make sure that you check them before testing, because you don't want to have a poor signal, poor ECG output during the test, and then you have to stop because of that. So kind of have them turn the wheels a couple times and move around and make sure that you have a good signal. As far as blood pressure, you want to make sure that you use the appropriate size cuff. This is an article that is published in Hypertension in 2005 that talks about blood pressure measurement. Blood pressure is probably the least accurate measurement that takes place during cardiopulmonary exercise testing. And that is because of all the interferences that are there, whether it be on a treadmill or a cycle. You inflate the cuff and listen for the crock-off sounds, and you end up with bouncing as they run along a treadmill, and or some type of interference even when cycling if you don't kind of cradle the arm a little bit. Standard and automated cuffs, you can use either of those. The automated cuffs, there are specific devices, and I'm not a champion of talking about specific devices, but there are devices that are automated that interact with ECG signal and sound processing and everything else that allows you to use these devices during exercise testing. And here Katrina, one of the supervisors in the lab, is measuring someone's blood pressure. She cradles the arm. This particular device has a microphone system in it, so you can hear the crock-off sounds nice and loud with a microphone within the bladder of the cuff. And or if you're using standardized blood pressure testing, make sure that the manometer that you're looking at is at eye height, so that you aren't influencing the measurement just by having something that's very low to the ground and you're looking down on it, or very high. So just make sure that it's standard height when you check the blood pressure. Pulse oximetry during the test, a tremendous adjunct. It's been around forever. One of the pictures that I have there, the black and white, is from the Mayo Clinic back in the 1940s with the aeronautical unit here. We were actually the first one to do ear oximetry, not pulse oximetry, but ear oximetry, and then moved on from there. AARC has a guideline, but it hasn't been updated since 1990. The Clinical Laboratory and Standards Institute has a guideline that was published in its second edition in 2010. Greg Ruppel and a couple other therapists contributed to that particular guideline, and it's an excellent resource for you. The big thing with exercise testing is that everything goes to core when you exercise, so the periphery, blood circulation kind of constricts down because your body wants to make sure that the blood is going to the major muscle groups and the legs and staying within your core. And where do we measure pulse oximetry? We measure it in the periphery. So make sure that you have a variety of probes. Make sure if you're using a finger probe or an ear probe that you rub that side up before the test and during the test, so that you get rid of the opportunities for false positive results. Reflectance technology is another type of probe that you can use. This is a great great adjunct to exercise testing and looking for exercise-induced desaturation, but be very careful with it and just make sure that you have the appropriate tools. If you have someone that has normal pulmonary function, normal DLCO, and they're starting to desaturate, you know, take that site and either move the probe to another site or take that off the finger and rub it up vigorously and place it back on. Even if your signal indicators are indicating that it's doing well, just move on from there because it'll make a huge difference. Blood gases can be done during exercise testing either by placing an arterial line or doing a single stick after exercise by having them lay their arm over the edge. There are guidelines related to the harvesting of blood, of course, that come from CLSI. If you're going to do it with a single stick at end exercise, make sure you get it within 30 seconds because everything normalizes very quickly when it comes to gas exchange. Ratings of perceived exertion. These are very helpful in monitoring the subject. So we have our feedback from our heart rate response. We have other things, but if we know how the patient is perceiving the workload, then that can be very helpful to us. There are two scales out there, the original scale from Borg and his modified scale, which was published a couple decades later, the 0 to 10 scale. You can also use visual analog scales, as we call them. So you rate or ask the patient if they have chest pain, and if they don't have any, they can shake their head no and or rate a 0 and or a 1, 2, 3, 4, 1 being slight, 4 being severe. You can also use this with other symptoms that they may have. Maybe they have lightheadedness during exercise or asthma symptoms, and you can also rate these as you go along during the test itself. And that will have some influence in, you know, not only monitoring of them and the symptoms that they're having, but also putting together their physiological response with the symptoms that they're having. And just make sure you give them feedback during the test. I'll tell you, a patient will go a lot further if they feel safe. Statements such as, your electrocardiogram and blood pressure look great. You're doing well. Keep going. You can go another minute, right? Thumbs up. And just encourage them, and you'll just much better VO2 max and quality of data if you do this type of encouragement during the test itself. It's helpful to understand some basic physiologic responses to exercise also, the cardiac response and the ventilatory response in particular, and looking at those things before the test and during the test itself. So from an electrocardiogram perspective, you don't have to know all of the different nuances of Winky Bach and secondary block and everything else. You need to know whether or not they're having an arrhythmia and ST segment effects, and you need to know a little bit about maybe the effect of drugs on their ECG. As far as the cardiac response, there are a couple different formulas as far as what their predicted maximum heart rates are. But that can be helpful. You know, your predicted maximum heart rate's 180. You're only at 150 now. Keep on going. I want you to get up there. And those type of things as far as encouraging the individual to give you a good effort. We also look at their blood pressure response. In the normal blood pressure response, the systolic pressure should increase during exercise, and the diastolic pressure stays a little bit more labile. It may go up slightly, but you certainly don't want it to fall. Now remember, blood pressure is the most difficult measurement to make during exercise accurately. So if you see that blood pressure has fallen from one workload to the next, it can mean two things. One, you didn't measure it accurately. The second thing is that there may be some type of hemodynamic compromise that is an important indicator for you. So take it again right away. If their blood pressure continues to fall, make sure you communicate with the patient and or stop and cool down at that particular point. And these are the definitions of hypertension for you that are on the slide. Ventilatory strategy or breathing reserve, knowing what someone's ventilatory capacity is important. This graph here on the right there comes from my book chapter in the Manual of Pulmonary Function Testing, and it just talks about ventilatory capacity, ventilatory reserve, and how we define ventilatory limitation. And we really don't have all the time right now to get into this, but if someone is reaching their ventilatory capacity so that they're defined as ventilatory limited, that may be the key that they've reached a maximum test. And so it's good to know those things on the front end. You can also look at their breathing strategy. And the very first thing I do when I start a test is look at their vital capacity, because they should reach about 50% of their vital capacity during exercise. So if they're sitting there breathing with a small tidal breath and very tachypnic, that's not using an appropriate breathing strategy, and you can coach them out of that, hopefully, during the test itself. You know, slow your breathing down, take slower, nicer breaths, and that will allow them to increase their VO2 max part. So this same breathing strategy is apparent in the pediatric population also. This is a document we published in Respiratory Care as an abstract and presented at the AARC forums on the pediatric response during exercise, and they also, whether they be a cardiac patient or a non-cardiac patient, use about 45 to 50% of their vital capacity during exercise. And these are all important things to know because it can help you when you're coaching the subject. You can look at flow volume loop profiles, and we don't have the time to talk about this right now, but some of the newer instrumentation allows you to look at flow volume loops during exercise, and you can then envision the normal response where we recruit from both our end expiratory lung volume and our inspiratory reserve volume, and or the individual with COPD that has to increase their end expiratory lung volume or their FRC and move higher to be able to recruit the volume needed, and are they flow limited versus ventilatory limited, and that can help you as you're defining or looking at the data after the test. Then of course we have to know the things as far as early termination, chest pain, ischemic changes, ventricular arrhythmia that say, hey, we have to stop this study. Other things like blood pressure, that the individual becomes very hypertensive and or falls, if we have a failure of the monitoring system and or if they have significant desaturation. During the cool down period, we want to monitor their system. We want to make sure in particular that we monitor if they get lightheaded. It's very common that a subject gets lightheaded post-exercise, even if they're doing a cool down. Somewhere in between 2 to 4% of the individuals get significantly lightheaded, and so we need to monitor that. We need to monitor their electrocardiogram, and then we always inquire why you stopped. Okay, why did you stop exercise? Was it because of breathing? Was it because of legs? Was it a combination of both? Because there's a big difference in between, I think it was my breathing, but could have been my legs, versus got tired, had to quit. So there's a big difference in between the amount of effort that a subject is getting, and sometimes that's important information to pass on. During the post-test also, thinking of this patho-workflow process, we need to look then at data analysis and selection. We need to, maybe take out several breaths where they were breathing inappropriately and will affect things. We need to make sure that we average the data and select data that's correct. We need to input ancillary data like our RPE values, our blood gases if we've got them, and other things like that, to make sure that we report information to the medical record, whether it be an EMR or the paper record, in a timely fashion. And this isn't necessarily related to cardiopulmonary exercise testing, but the ATS, through their Pulmonary Function Lab Registry, looked at turnaround time of reports within laboratories and reported that data at one of the AARC open forums in 2005. And the average turnaround time was less than a day for some institutions to greater than 7 days for others. And in this scatter, there was even a place that they averaged over 10 days to get their reports to the medical record. And that's where this whole process of looking across the path of workflow, every segment of your testing schematic as far as whether or not you're providing a good product. Because if you can't get a test out in a timely fashion, then that's not a good product to your clinicians. Biological controls have been very popular in other testing modalities. They're becoming popular in exercise testing also, because that's the only way you can really put it all together. Is the cycle ergometer working correctly? Is the gas exchange system working correctly? A lot of research studies are requiring this now as we move into the environment of looking at cardiopulmonary exercise testing as a research modality. And so, yes, you may need to do biological controls. How do we do that? Much like we do with pulmonary function testing, we have 1 or 2 individuals that do steady state testing below their anaerobic threshold, and then you run means and confidence limits for the primary variables, and then you perform this in a regular fashion. And then you just simply plot those out over time, and then I know that my system is working correctly or needs to have some type of adjustment. There was a paper that was put out in 2007 out of Casaberry's lab, and they looked at, instead of just saying steady state workload, well, what does that mean for any given individual? Well, they also stated look at 2 different workloads that are 50 watts apart, such as 20 watts and 70 watts or 25 watts and 75 watts, because then you would know that I need to have a 500 mil. Remember, 10 mils per watt is the normal workload to watt relationship, VO2 to workload relationship, so that I would need 500 mils change then in between that, and that way we know our system is working correctly. And then that ends the lecture. There is a tremendous amount of information presented, and I understand, I've just touched superficially on many of them, but wanted to give you an opportunity to have questions also. We can have, as technologists, therapists, or provider of this particular test, a huge influence on the quality of the VO2 max, the quality of the workload, the quality of the ventilatory response, and everything that the physician may look at as far as the output of the data. And we can also have a tremendous impact on making sure that our patients are safe when we're doing this test. And most of that is related to education and knowing what's going on during the test. So if there are any questions, I'd be more than happy to entertain them in the last few minutes here.
Carl, I want to thank you for just an exceptionally well-organized, information-packed presentation. Folks, you've got the professor's ear. Now is your time to ask the questions. We do have a couple questions to get us started here, Carl. The first one is, please explain why there would be more leg fatigue with cycling versus treadmill. When in cycling, there is less body weight needing to be supported.
Usually the leg fatigue, though, comes from not extending the quadricep in each one of those movements, and the workload is only applied to those particular quadricep muscles. When you're standing upright, you're moving more of your body, yes. You're moving more weight, yes. But the legs tend to adapt a little bit better because you can use your calves, you can use your quadricep muscles and everything all together. So there tends to be a little bit more leg fatigue with cycle testing, but you can thwart much of that by making sure that the saddle height is positioned appropriately.
Thank you. This one has to do with, the question is, are we allowed to say that the EKG or blood pressure is great? Isn't this kind of bordering on making a diagnosis?
Well, not really a diagnosis, but making sure that you're aware of what the normal responses are and when it is safe to proceed or not safe to proceed. Some of that is related to, do you have a physician present in the room? If you're doing it without a physician present in the room, then you need to be very familiar with these physiologic responses to make sure that the patient stays safe throughout the test itself. As far as pre-test, you want to make sure that you look at the electrocardiogram if it's available, or at least the initial electrocardiograms as they go across the screen, so that you can identify if there are any gross abnormalities that you may want to bring to the attention to the physician who's in the area, if not present in the room, and make sure that it's safe to continue. So you do have to have some basic knowledge that we all have, but of course we can also brush up on it a little bit as we go.
Okay, Carl. About obese patients, are there any clinical concerns or anything you'd like to say about this special group of folks?
Probably not, although with the obese patient, they have a shifted VO2 per workload. Fat does not consume oxygen, but fat makes the muscle work harder as far as its location around it. So let's say at 100 watts, I would expect someone to have a VO2 of 1300, because remember, 10 mils per watt, and then the resting value on top of that. So 1000 plus 300 rest is 1300. In an obese individual, you might have 1500 or 1600 for a VO2 at that given workload. So it essentially just shifts everything up. Other than that, you need to take that into account when you're looking at predicted values and other things.
Carl, one person wanted you to repeat what they should look for during the biocontrol data to verify.
Usually the best way, and I would point out Yannis's paper that came out of Rich Cassaberry's lab, is to look for, do two workloads that are 50 watts apart. Whatever you choose, you do steady state exercise for about 5 to 6 minutes at each one of those workloads, and there should be a 500 mil difference in between those workloads. Okay.
Another question is, how do you pick an anaerobic threshold?
Well, that would be a lecture in itself, and we could spend a lot of time on it. We didn't cover that. There are a variety of mechanisms that you can choose to select an anaerobic threshold: V-slope methodology, ventilatory equivalent methodology, looking at end-tidal values, and all kinds of things. I will mention, though, that we were doing a study here at Mayo that there were 3 individuals as part of the study took a look at and tried to identify the anaerobic threshold. I was one of those individuals for this study. So 3 blinded individuals, each one of them chose their own anaerobic threshold. In a third of the patients, it couldn't be identified. In a third of the patients, we got it exactly right. We had agreement within the 3 different individuals that were looking at the data, and in a third of the patients, we selected it at different points.
Okay.
So that shows you the accuracy of the anaerobic threshold.
Yeah. Any thoughts on people using a 3-lead EKG in pediatrics? Only a 3-lead EKG in pediatrics.
Excuse me. I think the minimum standard. Excuse me. I think the minimum standard is a 5-lead ECG, so that you have the limb lead and V5, because even in a pediatric group, you can have congenital anomalies that can create or cause ischemia, and so it's still important to have a minimum of that amount.
Okay. Okay. One person wants to know if you're willing to do a webinar in the future on the interpretation of cardiopulmonary stress testing.
Oh, of course, I would love to.
Okay, we'll keep that in mind. All right, let's see. I'm scanning down through these. How do you calculate which watt to use when using an ergometer?
That's as that example that I showed you. So
Okay.
take someone's predicted value using the demographic information minus their resting value and then divide it by 10, and that will give you the predicted maximum workload that they should reach. There are some other algorithms that are out there as far as individuals that have pulmonary disease. If your MVV is 40 or less, use a 5-watt incremental or ramp protocol. If your MVV is 40 to 80, use a 10-watt incremental or ramp protocol. And if it's greater than that, use that same calculation that I demonstrated for in the presentation.
Okay. We just have time for a few more questions, but do you recommend performing a spirometry or MVV prior to testing if no other PFTs are available? And what might be, and if so, what might be your preference?
Absolutely. We still perform the MVV here. The only problem is the MVV is more volutionally dependent than even the FEV1. If you're using FEV1, so you use spirometry, you use FEV1 to define the ventilatory capacity, then you need to multiply it times 35 or 40. We choose 40 because you're setting someone's ceiling, and they're not supposed to obtain that ceiling in normal individuals, and we didn't have time to talk about that physiology, but so use the FEV1 times 40 to define your ventilatory capacity or ceiling. The other thing is,
Carl,
that then that also gives you the data to know what their vital capacity is and what their expected breathing strategy or kinetics should be, so that you can coach them appropriately during the test.
Well, Carl, I am sorry we were out of time. We got through almost all the questions. I want to thank you again for obviously a presentation was very well received by our participants as I review the comments here. For those of you who are watching this as a live presentation, please stay with us during the next brief pause for instructions on how to obtain your CRC contact hour. If you're watching this program as an archive, this concludes our presentation.